Testosterone pellet insertion in-office procedure demonstration. Long-acting testosterone pellets were first approved by the FDA in 1972, but did not become commercially available in the United States until 2008. Each testosterone pellet consists of 75 mg of long-acting crystalline testosterone that is inserted into the hypovascular subcutaneous tissue. According to the FDA recommendations from 1972, 2 to 6 pellets are required every 3 to 6 months. However, physicians may use higher dosages based on the patient's response. Peak testosterone levels are measured 1 to 4 weeks after administration. If the testosterone level is more than 1000 nanograms per deciliter, 2 pellets are reduced from the previous administration. If the testosterone level is under 500 nanograms per deciliter, 2 pellets are added to the previous number, and if testosterone levels fall under 400 nanograms per deciliter, reimplantation is considered. Testosterone pellets, also known as Testopel, are indicated in cases where patients desire a more convenient form of testosterone replacement therapy. Compared to testosterone gels, Testopel does not carry a risk of transference between the patient and close contacts. Physician recommendation has been cited as one of the major factors that influence the patient decision to switch to Testopel therapy. Some studies have shown that the high cost of Testopel therapy may lead to patients seeking other forms of testosterone replacement therapy. Currently, 2 implantation methods have been devised for Testopel insertion. In the standard technique, all pellets are stacked and inserted into a single track from the skin to the subcutaneous tissue. In the modified V technique, pellets are inserted along 2 tracks with a 15-degree angle from each other, forming the shape of the letter V. The V technique has shown significantly less pellet extrusion and infection rates. The following video will demonstrate in-office Testopel insertion technique. Before starting the procedure, the prescribed number of pellets are emptied from the ampoules onto a sterile tray. The patient is positioned in the lateral decubitus or lateral jackknife position and prepped with iodine solution before draping. Local anesthetic is injected supralateral to the gluteal region in a fan-shaped pattern. It is important to hydrodesiccate and numb the entire length of the trocar insertion site, from the skin to the subcutaneous tissue. A small wheal should be created on the skin to indicate the scalpel insertion site. Using a stab knife, a small incision is made on the skin. Using a trocar with a sharp-ended stylet, 2 small tracks are made from the skin to the subcutaneous tissue in a V-shaped formation. The trocar should be inserted at a 45 degrees angle, facing downwards. After removing the sharp-handed stylet, the pellets are loaded onto the trocar well. In the V technique, the pellets are advanced into the tract using a stylet while withdrawing the trocar. The previous step is then repeated for the second tract. The incision site is then closed using a single 4-0 monocrystal suture. The area is then covered by a sterile 2x2 gauze. Pressure is applied on the incision site for 3 to 5 minutes to further enhance hemostasis.